I often tell my students that, when you grow up like I did in a village in Africa, if you can't stand your neighbor, you can't block them. Whereas today, on social media, if you become a nuisance, I simply just block you or I swipe and you disappear. But in real life, we can't do that. So we have to learn to live with people we disagree with. But in the social media world, you can actually avoid doing that. So you lose the skills to be able to deal with disagreement on a daily basis. Now, we also saw during the COVID-19 pandemic some serious ethical issues around access to resources and allocation of resources. Some of us in the African continent were simply just saying that, look, you are not going to booster vaccine yourselves out of this pandemic if we do not all have access to the resources. And then when we start talking about things like justice, the word justice has become so complex, and the dimensions of justice, from epistemic justice to intergenerational justice to distributive justice, restorative justice, transitional justice. How can we bring all these ideas into our conceptualizations of justice? Because most of the times when we're dealing with justice, we're just talking about distributive justice. And we talk about justice when we all, it's easy to have a conversation around justice if you all subscribe to the same epistemic framework, which is like many people subscribe to the liberal tradition. But when you have people who do not subscribe to that tradition, how do you talk about justice? Just to give you an example, two or 3 weeks ago, I was in India, and if you come from a culture where certain animals are sacred, it was an act of injustice to hurt those animals, right? Or if you believe in reincarnation, intergenerational justice takes a different type of meaning because it's not about future generations, it's about yourself, right? So even those concepts become more difficult. And that is why, talking ethics today is not easy. It's more complex and messier. Could you move to... Yeah. Anyway, the last part of that slide said, what is happening is, and this is the point I wanted to make, is so what we often hear in scientific spaces, and especially in medical ethics and medical research, is that we constantly say today there's a lack of trust in science. There's a lack of trust in expertise. There's a lack of trust in institutions. But what I want to do really is, to some extent, challenge that claim that there is, actually, I want to say there's too much trust. And I'll come back to why I'm saying that. It's not a lack of trust. But before then, let's just think a little bit around, bioethics. Trust has been at the core of the birth and growth of bioethics. Because if bioethics as a discipline emerged because of abuses that were committed in research, in medical ethics, and new technologies that were emerging and we did not know how to handle them, the core of the problem, one could say, is that people were, technology and politics was given power. And that power was not being exercised in a fair way. And therefore, we needed ethics to be able to protect the weaker part of that relationship in a way that the weaker part of the relationship will not become victim to the powerful part. And that is why at the heart of, at the heart of bioethics, we'll see that we tend to rely even on the human rights tradition, because the human rights tradition guarantees that our basic entitlements are given to us, that we should be able to have access to them. But in doing so, we've diagnosed the problem correctly as a problem of abuse of power. However, in choosing to respond to that challenge only by empowering the weaker side, we fail to address one part of the problem, which is why is the powerful part being unfair? And what needs to be done there? So you have a problem that stems from a conflict of two sides. And we have really worked very well in trying to curb the power of the powerful, so hold them accountable through bioethics, and give more voice to research participants, to patients, so they have to have informed consent, autonomy. We need to respect all those things. So we're giving more power there. But what we fail to do is to understand, is to question and challenge and trouble the structures that make the powerful become iniquitous. Why are they being unethical? And I think that is where the work needs to go. Now, so we've been able to, because of that, we haven't been able to address the structural imbalances very well. Let me see. Okay. But to be able to address these structural imbalances, to some extent, our bioethics needs to move a little bit from the purely neoliberal model or liberal model of being an individual-centered response to becoming a response that addresses the relationship. So ethics is not only about individual choices, because every choice takes place within a structure and within a context. And if that context is heavily unjust, it will condition even the individual choices. And this is where, I mean, structures like the National Medical Council actually have, a mission to take care of the ethical environment of a country. Just like we live in a physical environment, there is an ethical environment. And that ethical environment can be healthy, unhealthy, it can be poor, and it can be rich. And, when sometimes we complain about today's extreme politicians who use certain language and talk in certain ways in the public domain, what they're doing is they're hurting the ethical environment in which we live. That is also ethics. Anyway, let's move on before you start telling me it's time. Okay. So the claim that I'm going to make is that actually, when we start saying there is no trust, it's about lack of trust. I think it is actually wrong. There's too much trust. It's just that the trust is misplaced. So somebody who prefers to believe in a TikToker or a blogger rather than listen to the National Council on Medical Ethics of in Sweden is somebody who is trusting. It's just that maybe their trust has been placed in a wrong person or institution. So, and this is important to make this distinction. Otherwise, our responses to this challenge will not give us the results that we want. What we actually need is not more trust, but we need trustworthy institutions and persons. Because if you place your trust in a person or an institution that is not trustworthy, then you will end up badly. So what we need to build is not trust, but trustworthiness. But to build trustworthiness, especially in the health space, sometimes when we talking about lack of trust, we say, okay, let's go out and inform, let's give more data, let's give more evidence, so that let's explain things more. But you see, when you lose trust in an institution or in a person, that person can talk as much as they want. You think they're a liar. I mean, it even happens in our interpersonal relationship. When you stop trusting somebody, it's not their words alone that will make you change. You will need to look at their actions and need to look deeper. And so, we have this, sometimes we throw money at information campaigns. But you see, that is one of the errors of being privileged, I put it there. You see, privileged people and privileged groups always outsource problems. When there's a problem, it's with the other group. They don't have the habit, or we don't have the habit, I'll put myself among the privileged here, of looking inwards to say, what is wrong with me? Why does the public not trust us? Right? But if we ask that becomes uncomfortable. So it's easier to say, well, it's because the public lacks information or the public lacks knowledge, so it is their problem. And we go out to solve it for them again. That is outsourcing problems. So this requires actually asking ourselves as a scientific community, as health providers, researchers, what can we do to make ourselves more trustworthy? And Honora O'Neill, the retired Cambridge philosopher, talks about 3 conditions that actually renders an institution or a person trustworthy. And these are, 1, you have to be competent, right? You have to be competent in the field you're talking about, or in the profession that you're exercising. Now, I would say there is a great deal of competence in our field, in the medical field, medical research, medical practice. But that competence is actually also a narrow competence, because there is an epistemic bias in what we're doing. So we choose certain knowledges, and we don't respect all knowledges. So we have a very, let's put it this way, we have a very biomedical approach and a Western science approach. And that is the golden standard worldwide. How much knowledge do we have of, for example, non-Western traditions? Are we competent? And yet we want to sit down perhaps in Geneva and decide for the whole world, when we know, when we are incompetent. Unless, of course, Catherine is here from Geneva, from the WHO, so I'm not going to, she's a friend anyway, and I know the way she works. She tries to bring voices from all over the world, so I'm not the usual, bashing the WHO is like a hobby sometimes for some people, but that's not the case. That's not what I'm trying to get at. So, competence. Secondly, we need to be reliable, to be trustworthy. And to be reliable means, 1, to know, for the public to know that I am there for you, and that what we say is what we're going to do. And so if we ask ourselves about our healthcare systems, if my grandmother falls down and breaks her hip, and I'm looking for healthcare, is the health system there for me? That is a system that is reliable, because it says it is universal access, and when I need it, it will be there for me. Or to be reliable is also to say, well, let's go into lockdown, and when vaccines come out, you will receive a vaccine and everything will return to normal. Well, that is a lie. And when you say that and that doesn't happen, then you begin to be less trustworthy. Because many people's understanding of a vaccine, 5 minutes, and many people's understanding of a vaccine, at least from simple knowledge, is that when you take 1 jab, you're fine. Then you tell me, I'm going to take 1 jab, and you're going to open up and there'll be no lockdown. Then you tell me I'm going to take a 2nd one, then I'm going to take a 3rd one, then I'm going to take a 4th one. You need to justify that. You need to explain why you've changed. Third, to be trustworthy is to be accountable. And accountable means making yourself vulnerable. So we tend to think of accountability in certain directions. So a lot of us, if you're working in healthcare, your accountability is towards your employer, because that's the one that can fire you anyway. But how do you make yourself accountable towards your patients or your service users, or in research, or in public health? And do we even apologize to the people we're dealing with when we make mistakes? This is how to build trustworthiness. But you see, the direction I'm pointing in is a direction that is uncomfortable for us. It's easier to see that the public is wrong, or the public is uneducated, or the public is not informed. But if we want to recover that trust that allows us to build a healthy ethical environment, we need to turn the lights on ourselves as well. Next slide, please. Now, if we want to rethink medical ethics towards the future, we need to remember that health is a co-produced good. It is not produced only by specialists. Even the sick person with their illness is contributing to our understanding of illness. And since it is a co-produced good, we become allies and partners with everyone that we're dealing with in the health space because we have a shared vulnerability and a shared desire of well-being and health. This is what makes us allies. And if this is what health is about and healthcare is about, then ethics within healthcare becomes a custodian that promotes that relationship of health that binds us all together in such a way that that relationship can ensure that everyone within the relationship thrives. This is the game we're playing. It is not about, healthcare provider or healthcare whatever, but this is about a common good. And I could go on a lot about the shared good because one of the problems with healthcare around the world is that we have allowed health to become not a good, but a commodity. And a commodity is governed by certain rules that are different to public goods. And we need to keep bringing it back into that. There will always be a tension, but we need to keep bringing it back into that space. So allyship, mutuality, that leads to a less adversarial approach, even in ethics. I'm sure the speakers who will come may contest this, but one of the dangers of insisting only on human rights morals, the way it has been framed, is that it can lead to greater adversariality. Because human rights discourse is very good at pointing out our entitlements and less good at pointing out our duties. Next. So, anyone who knows me knows that I talk about solidarity all the time. So, one way of framing medical ethics in future is really to give solidarity a firm place in medical ethics. Because solidarity focuses on our similarities and not so much on our differences, because that is what brings us together, and that's what makes solidarity different to charity. Solidarity generates normative and duties of mutuality and accountability among those who are within the solidaristic group. So if we're together in solidarity, you don't betray the cause. And you owe certain duties of mutuality to promote this cause with us. It is under the aspect, because when we come together in solidarity, it's not everything that we are in solidarity about. If we are in solidarity about health, then under that aspect, we are all the same. It lowers the hierarchies. Just like, I often say, if we're together for Black Lives Matter, it doesn't matter whether I'm a Black person who is a cleaner or a Black person who is a university professor. Under that aspect, the hierarchies are kind of reduced. And solidarity also ensures that people within the solidaristic group do not fall beneath a certain threshold of need. And yes, it helps us to restore trust. I think my time is up. So I'm just going to say, as we continue looking forward to the next 40 years, we need to work on, or let me put it better, bioethics and medical ethics has done well in terms of defending, promoting individual rights, especially of marginalized and weaker persons in the relationship. The next step now is to see whether we can influence the ethos of the ethical environment by tackling the structural issues with different values. And those values, I think, are solidarity, subsidiarity, and pluriversality. Thank you.
Thank you so much, Cesar, for really highlighting and a powerful reminder, really, that institutions need to be trustworthy.